Hi and welcome to Local Women's Health Podcast. I'm Emma Heaney and today I'm joined by the wonderful Dr. Finbar McGrady. He's a GP with over 26 years experience with a specialist interest in dermatology. He's the founder of Dr. Finbar Skin Clinic, which is based just outside Newry, and today we're going to ask him all questions to do with skin. And I do believe you've been very quiet about it, but you've actually been nominated for Dermatology Skin Clinic of the Year, which is, when's that taking place?
Actually, Saturday night.
Saturday night. So good luck for that.
Thanks very much.
So Finbar, tell me about your journey, how you started the clinic, what was your sort of aspirations, and where did it all start?
Well, it was kind of accidental in a way. In 2012, I decided to take a sabbatical to Brisbane with my 4 young kids and wife.
Lovely.
Yeah, it was a trip and a half, and so I had a job as a GP there for a year. I took a sabbatical out of the practice. I was working in Crossgar at the time in County Down. But during that year, I was on my own in that GP practice, and people would come from Australia into me with skin check requests. You know, I've got skin cancer, doc, would you check me all over? And doctors or GPs in this part of the world aren't trained in recognising skin cancers or how to assess moles correctly. So I had to learn a lot when I was out there that year, and it was during that time that I'd done some courses, surgical courses and dermoscopy courses, and I really found it fascinating and loved it. So when I came back home in 2013, I wanted to teach other GPs, so I set up a group of education for GPs, and then that led to me getting a job in the hospital clinic in Craigavon, working there, and then built up into my own practice from the late teens, and that's just grown over the last 3, 4, 5 years into what it is today.
And I see your team's expanding. I was checking out on social media.
Yeah.
You have a new member of the team as well. Is it Dr. Christine's husband?
Dr. Christine's husband, Alan. So we have myself, Dr. Christine Glendinning, who's been with me now for, I think, about a year and a half, maybe 2 years. And then her husband, Alan, has just joined. Now, I've known Alan for over 10 years, and he's been doing dermoscopy and skin lesion work longer than that as well. So it's great to have him. And then Dr. Rosie Manson's also joined the team a couple of months ago. She's from North County Down, so she's a fantastic addition also.
And is Newry just your only location at the moment?
Yeah, Camla just outside Newry.
Sorry.
Yeah. So very close to the border. We get a lot of cross-border patients coming up, and even from the west of the country as well. So
from a referral point of view, can patients self-refer? Are you getting referrals from GPs? What way does the system work for your clinic?
Yeah, it's self-referral. People can book online. We also have a phone number people can call into, but the easiest way is to go to my website and just click on the links. It's very handy to do that. Now, as GPs with special interest, a lot of the private insurers don't cover us, so people are self-funding for this, so anybody can come. You don't need a referral, just book it online, give me a wee bit of information on there, and there's no problem with that.
Lovely. And I have to say, I've actually rang your clinic, and credit to your reception. He was fantastic and so informative.
Oh, that's great. Thanks very much. I'll have to give him a raise.
Yeah, really friendly, you know, which I thought, how would it be as if a patient, if I rang the clinic, how would that feel? So I just thought I'll go through the experience myself, and not that like I was a cold caller or anything, but excellent.
Well, that's really wonderful to hear, because it is one of the values that we have in our vision for the clinic, is to be friendly, kind, and you know, just compassionate and caring for our patients. So I'm really pleased to hear you give me that feedback.
Yeah, and I didn't want to tell you until right now, because I thought, you know, I know myself, I own a clinic, so I mean, your front of house is basically, it's a reflection of you, and it was an excellent reflection, so well done to your team.
Well, he was headhunted from the local hospital clinic, so really glad to have him.
Well, you can give him my praise, definitely. So the service that you offer, do you want to kind of give us an overview of what's available?
Yeah, so it's grown over the years, and I lead up on the skin lesion recognition front, so we do full body skin checks, and this is the system I learned in Australia, where not just like assessing one mole, so if somebody's coming in with a skin cancer concern, I check their whole body, because often we'll find skin cancers that they're unaware of, and it's very important with early detection to get them early, and then you can be treated much more easily. So I lead up on the skin lesion. Dr. Allen's joined now. He will also be doing moles checks and skin lesion checks, and then Dr. Christine and Dr. Rosie will be leading up on the inflammatory conditions, so that's acne management, eczema, psoriasis, and other unexplained rashes and itches.
Lovely. So we'll go back to moles, because as we know, we've talked off camera that this is Skin Cancer Awareness Month in May. So let's talk about your mole mapping and your scanning, etc.
Yeah.
Tell the patients and the listeners how do you come with a concern? What are they looking for?
Okay, so first of all, it could be because of your history. You have had a lot of sun exposure in the past. You work outdoors maybe, gardeners, farmers and bricklayers are my two most common clients because of the amount of sun exposure they get over their lifetime. But it is cumulative over your lifetime, and it's also important to not burn early in life as well, because that can lead to damage in the future. So people who have lived overseas, spent a lot of time outdoors, or used the dreaded sunbeds, so we'll avoid that maybe if possible. So if you've got those risk factors, and or you've got a family history of melanoma or skin cancer, then you might want to come in for a full body skin screening. Now there's lots of technology, and I use technology in my clinic as well, but by far the most important thing is to have an expert eye with the dermatoscope. It's a handheld tool that we use, and that needs to go over your whole body, and we look through it to assess all your moles and skin lesions, and that is the mainstay of the skin checking system. We can enhance that with total body photography, which takes, in our clinic, 35 photographs of each part of your body, and we store them safely and securely on your digital record, and they're used as a reference point for the future. And comparisons can be made. AI can help look for changes in the moles over time, but that's really a tool that assists me and my colleagues with the actual manual screening with our own eyes. So AI is very important, but it's not going to take over the hands-on job of a real human.
I think that's a massive fear, isn't it? But I mean, again, for me, equipment's only as good as the person that's using it.
Exactly, it's a tool.
Yes. So moles, explain what patients or clients or listeners should be looking for, changes, what I know there's like an algorithm.
I'll go through the algorithm in a wee minute, but I think important to give people a little bit of respect for their own intuition, because that's one of the things I'll tell people. Look, if you think that there's something wrong, if you feel that there's something wrong, get it checked. Okay, so that's really important to use your own intuition. But it's interesting just when you mentioned that about what to do with your moles. At this time of the year, especially now the sun's coming up, and people will very proudly tell me that I've got a plaster or a band-aid and I'm covering my moles when I'm outside, and I'm asking, why do you do that? They think they're being good, that they're protecting their skin from skin cancer, but actually moles aren't harmful. So that's one of the biggest myths I want to dispel. People think that moles are dangerous. Moles are entirely normal, and many people have multiple numbers of moles. The problem arises if you have hundreds of moles, especially if they're irregular and different shapes and sizes, because it might be that within that group there's a skin cancer that's early that we aren't able to recognise early enough. So people with a high number of moles are at a higher risk. But covering your mole with a plaster is kind of unnecessary, because most melanomas, which are the most nasty type of skin cancer, they arise in a piece of normal skin and not in a mole at all. So only about 1/3 of melanomas will develop in a mole that you've had, whereas 2/3 of melanomas will pop up in a piece of normal skin. So it's really, really important to look for new things. So new things, and where your intuition tells you need to get it checked. That's really important. Now, if we go through the algorithm of what people are advised, that's the ABCDE. You'll hear this across all the podcasts and in all the columns. And this is useful, but it can also lead to false positives, meaning lots of warts. Look with the ABCDE criteria. Let's go through them. So A stands for asymmetry, so that's not equal on one side to the other. B stands for irregular borders or edge. C means 2 or more colours. D is a diameter greater than 6 millimetres, but that doesn't mean you can't have a skin cancer smaller than 6 millimetres, so I don't particularly like that. I prefer to say to people for D, look for things that are different from all your other moles. So people who have a mole, they'll have multiple moles, but they'll all be very similar looking. So if one looks different, that's really important. And then E stands for evolution or evolving. That means changing over time. Now with the ABCDE, you can have a seborrheic keratosis, which is the most common benign skin lesion. I'm sure you see them all the time in your clinic as well. They can be asymmetrical, have irregular borders, more than one colour, be greater than 6 millimetres, and be changing and bleeding and itching. So not all things which fit those criteria are skin cancer, but those are the sort of alarm bells that you should go and get it checked just if you have those. I want to add a few more, if that's okay.
Absolutely.
So I also tell my patients about E, F and G, and that stands for elevated, firm and growing. because I've had 2 of these particular types of melanoma skin cancer in the last few months in my practice, elevated, firm and growing lesions, and they're often pink in colour, not the irregular brown thing that you'll see in a lot of melanomas in textbooks or online. So elevated, firm and growing lesions also need to be seen really quickly, because they can actually end up being the nasty, deep, thick melanomas, and they're not always pigmented.
That's really interesting, because I think as what my ladies would ask me in my clinic, and I'm like, well, I just refer on. It's not my specialty. I know what I'm good at, and if I see something, basically, if I see something a little suspicious or I don't like the look of, and again, going with my own intuition, I just say to my patients, listen, I think that needs to get checked. You know, and I think, like you said, if your gut feeling says this isn't right, then contact Dr. Finbar.
And that works for clinicians as well. We have a gut feeling, and as you describe it there yourself, it's a reaction, this isn't right, you know, and we need to take further action. And further action might involve monitoring it, so taking a photograph and seeing you back in a few months. But more often, and that's actually quite a rare case in my clinic, if I'll usually give you a definite benign diagnosis, and where I can't, then we do a biopsy of some sort, and that means either removing part or all of the lesion and sending it to the lab for analysis to get a definite confirmation of what the diagnosis is.
And your time turnaround for your histology or your biopsy?
Yeah, I send them over to a lab in England, and it takes 2 weeks.
Right. That's not too bad for patients to wait.
So some other labs take longer than that, but I think it's very important, especially when people are anxious. They want the answer right away. I don't like to have people waiting, so I do keep slots blocked. So when people come to see me, I have slots that only I can fill that aren't available online.
I have them too, funny.
Yes, we need those, because we need to say, if somebody comes in and they've got a suspected skin cancer and they want it removed, they'll want it removed next week. They won't want to have to come back in 6 weeks or 2 months to have it removed.
And a week seems like a year when you're worried about something. Yeah. That's really good. So when you said about you removing them, so explain to the listeners, what is the process? You know, like I know, but just for them to know so they're not frightened.
There's different techniques that can be done, and this is one of the reasons why we have a consultation first with patients as well, to do the assessment, to make a diagnosis, but also to decide what surgical technique to use. So they range from, for benign lesions, we can do cryotherapy on the day, which is freezing them. But if we do need to remove something in its entirety, we'll do a procedure where we numb the skin with local anaesthetic. So in my clinic, they're all done under local. There'll be nobody put to sleep, but you can drive afterwards. And so the biopsy techniques are including a punch, which is a little round device, which, like an apple core, takes a piece out of the middle of a lesion. Sometimes they're big enough to remove an entire mole. For example, a facial mole that's raised, they can go around the outside and take it all out. Then there's a shave biopsy, which literally shaves it off flat. And then we have curettage, which is a bit like a sharp spoon, which scrapes a thing off. So some sun damages respond very well to that. And then if we're going to remove a lesion in its entirety, we just use a scalpel blade and take it out in an ellipse shape, so that we can get enough skin to close the wound together with stitches afterwards. So we close all the wounds to make sure they heal fully.
I know you said about not wearing a plaster on it, and I know you see lots of people walking about with them. So can we ask the question about SPF?
Yeah, we should close the loop in that plaster. I don't think I finished that, sure. Thanks for bringing that up again. So my point about not putting a plaster over your mole, the moles aren't dangerous on their own. So the pigment in a mole is really, the body's really smart. So the pigment is arranged above the nucleus of the cell. So the nucleus contains all the DNA of the cell, and that's where skin cancers can develop, from the DNA, when the DNA gets damaged through sunlight. But a mole has the pigment overlying the DNA between it and the outer surface of skin. So it's almost like a little umbrella from the sun. So the mole actually is more protected than other parts of your skin. So if you're covering a mole, which is less risky than the other parts of your skin, that's why I say the plaster's unneeded. You need the UV protection across your whole body. So moving on to UV protection and SPF, and I'm going to put SPF down the list in my priorities here. Okay, so personally I have a hat in the van and sunglasses there. So hats, clothing, UV protection are way more important. Sun protection is I think over emphasised in terms of sun protection, and the other basics aren't adhered to enough, first of all. So for clothing, first of all, avoiding peak UV in the midday and lovely weather like this here.
I know.
So just avoiding a little bit, but I always tell my patients to get outside and enjoy the sunlight, but just be careful in it. So if we're coming on to then SPF, there's different types. You know well enough, you're telling people this all the time. And so I have different types of people. So one group of people that I have are those who are so anxious about skin cancer they don't go outside, and they are white and they are not getting enough sunlight and they're not getting their vitamin D made.
Yeah.
So balance in health is so important. And so I'm encouraging these people to get outside more into the UV light, into the sunlight, obviously not overdoing it.
Yes.
So that's the first part. The second part is those people who have a lack of awareness, maybe who use sunbeds or do other poor health behaviours, getting too much UV, and they're the ones then I'm trying to encourage to use more UV protection. And if they're not adhering to the clothing methods, then if they put the creams on. So everyone, if you're wanting to prevent signs of ageing, so the UV is one of the biggest contributors to collagen degradation, isn't that right? So it leaves your skin less elastic and more prone to wrinkles and things like that. So what I would say to them, 12 months of the year, use your SPF every day if you're wanting to prevent the signs of aging. However, if you want to prevent signs of skin cancer or skin cancer itself, then really you don't need sunscreen every day of the year. You could use it from March, April time, right through to the end of September, in our climate now in Northern Ireland, that is, unless you're going on holidays. So March to September, and you use it when you're going outside, and that's to prevent sun damage that'll cause skin cancers.
Yes.
Now, SPF comes in different grades and forms. I basically say don't go below factor 30.
Yeah.
And the factor relates to the UVB proportion of the sunscreen. So there's UVA and UVB, which will cause damage to the skin. UVB, B stands for burning, burning of the skin, and A stands for aging. And A will sometimes get through glass that hasn't been treated. And so we have to make sure that if you're indoors and you want to prevent aging or the sunspots, which UVA also causes, the solar lentigo and age spots, people don't like those either.
No.
So we got to use a high UVA rating in our sunscreen as well. So I have a couple of products that I list on my website, but there's lots of out there.
And when you hear like SPF, 50, 30, there's not much of a difference in percentage cover between 30 and 50.
Yeah, the graph, if you look at this in the chart, the first from factor 5, 10, 15, 20, it does, the protection improves greatly, but once you hit 30 it starts to even off, and 50 is not much better than 30. The issue about putting it on though, people recommend putting on 50 because most people don't put enough on. So if you're not getting enough on, you're probably better going with 50. Yeah. You'll get more coverage probably than using 30 not enough. Using 50 not enough is probably better than not using 30 enough. but if you're getting 30 and a good coverage, then you're doing well.
I sort of use the rule of thumb when I'm sort of speaking to my ladies. It's a 2-finger rule. Okay. And if you've put the cream on the 2 fingers, and that's to do your face and neck. Right. And that's the right amount, roughly. So I always talk about the 2 fingers. Okay. I'm a factor 50 girl because obviously the burning, but also the aging. We do not want to age any quicker than I am. So we go on the 50, but we also have that conversation a lot of times. Oh, well, it's in my makeup. And I'm going, it's SPF 15. It's not enough. Yeah. So I'm quite strict about that. But it's good to get you here to sort of dispel all them myths.
And I'd agree with you. It's not enough in the makeup and probably not putting enough on either. But there's no harm in having it in your makeup foundation if you're going to apply on top as well. So I would use both. And
I would always say too, if you're in like this beautiful weather here, every 2 hours to reapply. Yeah. But if it's a dull day, it should be a 4-hour reapplication. Yeah. And I don't know, are you? Well,
look, I try to be as pragmatic as possible because my client base might be different from yours in a lot of extent. So the guys and the ladies who keep me working the most with removing skin cancers would be farmers, bricklayers, people who are outside gardening a lot. And to try and get these people to use sunscreen at all is a bonus if we change behaviour. So I'm often telling my clients and patients, look, put your sunscreen beside your toothpaste in the morning. Get it on you before you look at the weather. Don't even check if it's raining or cloudy. Get it on you because that's your chance. Just don't mix the toothpaste and the sunscreen up.
Definitely not.
But also to keep some in the van. But even that's a bit of an issue because if it's sitting in a hot van all day, it's probably degrading over time. Yes. But trying to get somebody to put it on at all is you're getting somewhere. But yes, so the 2 and 4 hours after, that's an extra bonus if you're a motivated person.
I think because you've come from, you went to your sabbatical in Brisbane. I mean, Australia are just like the children are wearing big hats going to school. I mean, I think we are definitely, I mean, we don't have the same ozone damage here, but we don't have the same sunlight here, but I think they're so ahead of the game. Like I remember we were there 20 years ago and obviously back then I was looking for a lower factor because I thought, and like a tan when I was away, and you would struggle to get anything under factor 30, and that was back 20 years ago. Yeah. So I think we're catching up.
Yeah. So the slip, slop, slop campaign in Australia happened away, I think it was the 80s, and they're only now seeing the benefits of that 40 years later.
Right.
Yeah, it takes that lag to come through. The behaviours of the population takes a long time to change. So their older population, in a way, are maybe going to miss out on those benefits, but the younger ones coming through, they're starting to see a reduction in the incidence or the increasing prevalence of melanomas. So it takes a long time. So hopefully our behaviour will mirror that now. I think a lot of younger people are more mindful of the UV protection.
They definitely are. Yeah. Absolutely. I mean, they're more for using fake tans as opposed to using sunbeds and things like that. They're definitely much more aware, and they really are into their skin now, where probably my generation, only I was very lucky. My mum was very much into her skin. She kind of protected mine straight away. But yeah, I think we are seeing changes and trends. I do find it difficult at times to get the SPF message across, and probably we are going for the skin cancer, but I think if I mention aging, aging, absolutely, because I have a different clientele than yourself. So I just mentioned you're spending £200-300 on your skin, buy an SPF, so that's kind of my angle for when I'm doing it.
Because aging is marketed very heavily to people, and there's a massive multi-million, billion industry, isn't it? And there's only really, the main product that works as an anti-aging is SPF, sunscreen. That's your mainstay of anti-aging, really.
Yeah, and we all want to sort of stay as youthful as possible. So you've talked about your body scan. Is that the first in Ireland or in the north of Ireland?
No,
or is there others?
There are other clinics who do that, but I think we're quite unique in that we marry it up with the full body skin check.
Perfect.
Yeah. And the photograph, we use that as a tool. But ours is a very affordable system.
Yes.
More than some other areas.
And as you said, it's not covered by private health.
It's not covered by private health, so it's an investment in your health.
Yeah, and it's important, absolutely important. So, I mean, we could talk about moles, skin cancer for the entire podcast, but I want to sort of give a little bit of focus to your other skin services that you provide. I mean, I went on your website and I really enjoyed reading through it. I thought, God, this is great. It's a really good service. Pity you're not closer to me. Okay. But you talked about acne and your acne services, and you have a fantastic YouTube podcast, I think it is, with regards to talking about teenagers and acne and dispelling myths. And
well, I have lots. Just you mentioned the YouTube. I have lots of videos on YouTube, but I have them linked via my website. So if anybody wants to access them, I've got freely available information on my website blog. If you just go to my website, drfinbarskinclinic.com, and go to the free patient resources section, I'll put the blog post in and the link to the videos I've made on moles and skin cancer and a variety of things. And then the one you mentioned then on teenage acne, I think that was an important one to make, because there are a lot of myths out there about acne, and one of my bugbears is the massive amounts of cleansing that people are advised to do, implying that acne is somehow related to poor hygiene, and it's wrong, because a lot of teenagers will come in then thinking that they're dirty or greasy and the reality is it's not their fault. It's mainly a hormonal driven condition of the hair follicle and oily gland that's associated with that hair follicle. Yeah,
and I think that's a really important point, because they do think they're dirty, and they're not.
But sometimes, no offence to the ladies maybe listening to this, but sometimes the mums can actually amplify that as well and buy extra cleansers for their kids, and it's not really a cleansing issue.
No, and I think by over cleansing and over exfoliating, your the skin barrier gets damaged as well, and you then start that vicious cycle. So that's really good to let the mums know that if they are listening to this, what tips would you give them for their teenage children that are currently having the outbreaks?
Yeah, just on that, just to avoid the over cleansing, over exfoliating and popping, squeezing.
Popping the scars, I deal with scars a lot.
It actually causes more inflammation of that hair follicle unit, so it can lead to deeper, more inflamed skin underneath. So I would generally, I give my patients a little a skincare plan then, and there'll be prescribed treatments on there, obviously, and they'll usually involve a retinoid cream, but the management, I'll often reduce back the cleansing that they're doing, put them onto a simple SPF again. Often recommend a mineral one, that's one containing zinc or titanium rather than the chemical sunscreens, and they may be less reactive to those. But also then at night time to moisturise after they've had their treatments, their prescription treatments.
Well, you just touched there briefly on retinoids. There's a lot of stuff on TikTok and quite incorrect information. And I think they sometimes think, oh, retinoids is for anti-aging again. But yeah, I have acne patients that are on retinoids. Do you want to explain why?
Yeah, so they do quite a few things in the skin that's really beneficial. I think they get a bad press from people who misunderstand them. And back to the anti-aging, along with sunscreen, retinoids they're the two massive ingredients for anti-aging. They restore collagen, but that's not how they work in acne. In acne, they work by their effects on these oil-producing glands at the hair follicle. They reduce the oil, they keep the pores clear. So they do all the exfoliation by themselves, so you don't have to really. So that's really important. And retinoids come in creams that they're prescribable. You can also get them through online prescription websites. There's Dermatic and there's Skin and Me and there's a few others, but that requires you to engage with a online consultation.
Right.
And then retinoids also include the more oral form, Roaccutane, and the generic name that's isotretinoin, and that has got a bad press in certain circumstances, but it's still the actual most powerful and effective tablet for acne. Although thankfully not everyone needs to go on it, but if you do need to go on it, it's a wonderful drug.
Yes, I think again it's for the right person.
Yeah.
It's the right treatment. There is some side effects too, and it shouldn't be abused.
Exactly.
That's I think why GPs and dermatologists are very selective how they prescribe it.
Exactly, that's why you have a consultation. We have to go through all the side effects and go through the benefits and the harms. It's our job with you to try and come up with a joint plan that we both are comfortable with for you, and make sure that you fully understand what you're getting yourself into. Are you prepared to put up with those potential side effects in order to achieve the benefits that you want to achieve? And that's where it comes down to. That's why we don't tell people what to do.
Yeah, and I think that's really important. It's the risk ratio, benefit ratio. Yeah, and I mean, that's with every consultation. I mean, for every condition.
Should be.
Yeah. Well, and good practice. So let's move on to eczema. That's a big one. I know you have the two lady doctors, but could you talk about your services?
Yeah, for sure. So eczema is a variety of conditions actually relating to dry and itchy skin. And there's atopic eczema, which starts in childhood and is associated with hay fever and asthma, and that's a particular type. And then there's multiple other types that people can develop later in life, and that often causes a lot of confusion. Why did I get this? I've never had it before. So seborrheic eczema or dermatitis. And this is another thing about dermatology and skin. There's different words invented which mean the same thing, which just confuses people no end. I was making a video earlier this morning about chondrodermatitis nodularis helicus.
That was easy for you to say.
Yes, that's been saying it all morning.
Not the rest of us.
So there's an example of something that means chondrodermatitis just means there's a wee bump in your ear that's sore due to the inflamed skin. Right? So how simple is that? But the words are Greek and Latin and they sound terrible. So it's the same with the eczema. All these words, we need to demystify these things. So just think about eczema, dry, itchy skin. Sometimes red, sometimes a bit scaly. But the mainstay of treatment for eczema is to moisturise. But I get numerous questions about dietary relationships, is it caused by this or that? And while there can occasionally be dietary and allergy related topics that flare in them, in children in particular with atopic eczema, it's usually the eczema which may lead on to allergies. When the kids are the baby, if you remember back to having toddlers and they feed themselves through their skin, it gets everywhere, that can get through the skin and trigger an immune response to that food. So it's not the food that's causing the eczema, but the other way around potentially.
Right.
Okay, so we need to heal the barrier up with moisturisers and ointments, and there's recent studies to say which is the best, lotions, moisturisers or ointments, and it said, look, basically if you're applying them enough, they all work.
Right, that's good, because it is a minefield.
Yeah, there's so many creams out there and people get worried about the minutiae. Which one? I'll try this one, I'll try that one. They're all much of a muchness in a way, and it's more about consistency and picking one that you like. You like the feel of that doesn't have too many added fragrances or added chemicals in it.
And so, do you see babies in your clinic as well? So if I want, obviously mine are big lads now, but if I had a baby that wanted to be seen, you see babies as well.
Yes.
That's lovely. And I mean, I suppose a topic of mine as well that I do love to talk about is rosacea.
Yeah.
I know last month was Rosacea Awareness Month, and we did a lot of work in our clinic with regards to that. But it's a management of it. You're never going to fully treat it, but could you maybe explain to our listeners about rosacea and the management and the triggers and demystify the myths about it?
Yeah, so I get a wee touch of rosacea every now and again myself. It seems to be very common in our blue-eyed, white skin type phenotypes. So it's an inflammatory condition, a bit different from acne, although often confused and mixed up between the two. It's mostly around the nose and the cheeks, but can be around the eyes and around the mouth as well. Perioral dermatitis is like a cousin of rosacea, so they're related. Often triggered by an overgrowth of Demodex mite in the skin. I don't know if you talked about that much last month in your topics, but that can lead a very satisfactory treatment by reducing that particular cause. But like eczema that you mentioned earlier, there are overlaps with things like stress, things like not sleeping well. All this is affecting our immune system, and we'll have to let our immune system recover and heal. If we're overdoing too much, we're looking after half the country, our kids, our mothers and everybody else, and not giving ourselves a bit of TLC. That's often where I'll start. Did you have a coffee with your friends recently? You know, you need to take some time and relax the whole, calm down the whole immune system, and that involves, you know, good emotional health, good emotional support, family, friends, sleeping well, not being stressed. Easy thing to say, difficult
very
to do.
Very easy, yeah, very difficult. And that sort of takes into, I mean, I read on your website about your holistic approach. That just really leads into that.
Yeah, try to, because, you know, I'm a human as well, and, you know, you experience things in life and you learn from them. And, you know, we're taught in medical school the medical model of things.
Yes.
And we often get missed that, you know, that human beings have so much more going on than, you know, a pumping heart and breathing lungs. You know, there's a bigger thing at play here. And so that's why where possible, will try and bring in lifestyle factors into every consultation. So important.
It really is. I mean, and the emotional impact on skin conditions.
Yeah,
is
such a psychological, and then that's a vicious circle. Because
Yes.
then people, if they've got especially a facial rash like eczema, and they don't want to leave the house because of it, and then they get more stressed and get more lonely, causing more stress and more rosacea, and it just is a
like a
vicious
cycle.
cycle.
It's very difficult to break. From a treatment point of view, what would your gold standard treatment be for rosacea?
Well, again, when I look at it with my dermatoscope, that magic tool
Your
that
best
has
friend.
replaced my stethoscope now. So if I do see a lot of the Demodex, we use a product called ivermectin topically, which is traded name Sulantra. Occasionally we'll use an anti-inflammatory antibiotic for a little while. There are other creams that some people use, retinoids, but that's whenever the skin's settled a bit.
Yes.
So yeah, those are the mainstays of the medical management.
And treatment protocols wise, would you use any technologies?
We don't. So our clinic is pretty much based on the human interaction, and then the surgical side and cryotherapy and prescriptions. We don't do any lasers or microneedling or anything like that.
Okay, lovely, thank you. And so the plans, what's happening next for you? What is happening with the skin clinic?
Well, I have a wonderful problem in that I am seeing demand increasing all the time. People are wanting their skin checked, they're wanting to come with their problems, and that's a success of the clinic. However, it leaves me with a problem in that there's only one of me, and only so many days that I can work safely before I start to get burnt out and need that emotional support myself.
Yes, I can relate to that, I can.
So that's why I'm so happy to have Dr. Rosie, Dr. Christina, Dr. Annan as part of that team. They meet my values as well. You know, they're totally friendly people, they're very kind, they're very compassionate, they're very good at their clinical work as well. So that's really important. And if I'm able to give them more hours of work, that'll be fantastic. But growing the personnel will be our next protocol. Yeah.
And that's difficult because you have to, as you say, they have to match you.
Exactly.
Because so opening hours at the moment, the clinic, does it have late evenings?
So we work Monday to Thursday at the minute, and it's pretty much, we'll do an early morning. We start just after 8 in the morning, and go on to 4 or 5 most days.
Lovely. And so you have a Friday off?
I take a Friday off. That's the day the visit parents, and also band practice day on Friday afternoon. Very important as well.
So and you'll be off this Friday to prep for your awards then and get your outfit
Oh
ready?
yes, that's right. Actually, did have to go down and get my suit measured up on Saturday there. Yeah.
Oh, well, brilliant. I will be watching social media. Definitely. I'll be wishing you the best of luck.
That should be fun. Thanks very much.
Not at all. I want to thank you very much. I mean, I could talk to you all evening. I just think this is such an interesting subject, and there's so many questions that need debunked, they need demythed, and I think follow you on your YouTube channel. get onto his website, because there really is a free platform and you just click the link, and I learned so much myself. So, thank you very much.
Thank you.
And when moving forward, I hope you get a bigger team. I hope you expand and different locations as well.
Thanks
I
very
wish
much.
you all the best.
Really appreciate that, Emma.
Not at all. So thank you very much to Dr. Finbar. And if you want to know more, go onto his website, drfinbarskinclinic.com. Did I get that right?
That's right, perfect.
Yeah, I've been practicing that all morning. And also definitely go onto his YouTube channel.
Yeah, you can find me on social media at Dr. Finbar, DrFinbar.
And he has a ponytail, so it's not a different person.
Yeah.
You need to update them pictures.
New photographs required. Yeah.
Thank you.
Thanks.